Okay, good morning, everyone. We're going to get started. Welcome to the Division of Cardiology Wednesday morning rounds. Just before I introduce Ali, I just have a couple announcements regarding rounds, just a brief comment on structure. Once a month, usually the first Wednesday of the month, the rounds are a UOHI-wide rounds. So we call those grand rounds. They're organized by research services, and the speakers are broad and meant to represent the four divisions within the Institute, so cardiology, cardiac surgery, cardiac anesthesia, critical care, and prevention and rehab. And those rounds are organized by research services. They are planning their next academic year. And if you have speakers that you would like to be invited to those rounds, they're usually distinguished speakers of international prominence in their area of field. Please send name or ideas to either research services or myself or Dr. Burney, and we will get those names forwarded on to try and recruit some of these speakers. If you have names that perhaps are more specific to cardiology that you would like to come and talk, also please send the name to me, because if they're not appropriate for grand rounds, then we'll try and schedule them into the Division of Cardiology rounds, which are the remainder of the Wednesdays in the month. So brief announcement there. We're going to move on to Dr. Hillani's talk. So he's one of our interventional fellows. As you can see, he's done several fellowships in interventional cardiology, advanced cardiac imaging, and now here doing a CTO and TAVI fellowship. So we welcome him today and look forward to his talk on how to stop heart attacks. Welcome.
Thank you. Good morning. Good morning, everyone. In the next minutes, I would like to discuss the data and rationale with subclinical atherosclerosis and if there is any way to prevent a heart attack. I would like to start with a case because it goes us in deep with what we expect from this topic. It's a real case that happened during my fellowship last year. So let's begin. I have nothing to disclose. Not working here. Okay, a 31-year-old female patient who presented for exertional angina of 1 month duration. Past medical history is negative, no diabetes, no hypertension, no dyslipidemia. Patient is non-smoker. Family history, just her father had MI at the age of 58. She underwent exercise stress test and it was negative clinically and electrically. So her cardiologist discharged her on no treatment based on the demography. 6 months later, worsening angina over 2 weeks. So she sought medical advice and went to the emergency department for chest pain, and she was diagnosed with non-ST elevation MI, and they request for her a left heart cath. Here is her left heart cath. This is a cranial view, and as you can see, pointer is not working here, but you can see proximal mid-LAD, there is some irregularities, and so for the apical LAD, and it was, they said it's around 70 to 80% lesion involving proximal mid-LAD as for the apical LAD. And based on the demography and for the absence of risk factors and the presentation, they labeled her as having spontaneous coronary artery dissection for the proximal mid-LAD and for the apical LAD. And based on guidelines, patient was discharged home on aspirin with a follow-up in 6 to 8 weeks. So we cannot go through this case without saying a few words about atherosclerosis, and understanding atherosclerosis and plaque formation is of paramount importance. All start with endothelial dysfunction. We we have biological problem or some dysfunction mainly affecting the endothelium. Most probably it's obesity, diabetes mellitus, or even smoking. After endothelial dysfunction, we start having endothelium becomes permeable, allowing movement of lipoprotein, which permit of recruitment of inflammatory cells, mainly macrophage, that ingest LDL to form foam cells. And the next step will have vascular smooth muscle proliferation, which leads to fibrous gap formation. And as a cardiologist, we know that coronary artery disease is bad. And why it's bad? Because it causes heart events. We have atheroma, which cause significant stenosis, lead to ischemia, and by consequence, we have events. And in our daily practice, we try to find coronary stenosis, to detect stenosis in order to find ischemia and treat it to reduce ischemia and reduce events. And we had a lot of data that we are happy to share with our patients. And the vast majority of this data saying that ischemia is of paramount importance. And those patients with high burden of ischemia are associated with higher rate of death and myocardial infarction. Yet, the correlation between ischemia and luminal stenosis is poor. Maybe because coronary artery disease is driven by some biological process, most commonly is inflammation, which is not well reflected or fully reflected by percentage of luminal stenosis. So here, as you can see in this paper published on JACC, in the first up here we have, usually we deal with our patient either in secondary prevention or primary prevention, but it's uncommon to see our patient at early stage when the atherosclerosis started, at the beginning on the left of the slides. So, question. We have to understand that atherosclerosis usually has a three main presentation. We have asymptomatic disease, which is characterized by intimal thickening, intimal exanthoma, or thick fibrous gap. And we have unstable disease, which is mainly characterized by large plaque burden, thin fibrous gap, and calcified nodule in 3 to 7% of cases. And stable disease, usually we have stable plaque. It's not soft plaque. It's characterized by fibrocalcific plaque. So in this paper, I'm trying to divide this paper into two parts. First one at the left here, which is I will call the slow progression of atherosclerosis. It takes months to years. And as you can see up on the circle up from A to F, atherosclerosis is under progression, and this is the natural history of atherosclerosis, but you can see lumen is fixed, is relatively stable. However, atherosclerosis is under progression, and this is mainly due to positive remodeling, which is defined by outward expansion of the plaque without infiltrating the lumen, until reaching some points, which is divided here by points, where we switch to quick phase or rapid phase. We don't know what is the trigger point here to switch from slow to quick phase, but usually here it's characterized by intraplaque hemorrhage, and we stop having positive remodeling outward of the vessel, and everything starts inward. So we start having decrease in lumen, and we have enlargement of necrotic core, rupture of the plaque, and thrombus formation leading to ACS. So now the main question, can we detect atherosclerosis earlier? Sure we can. We have two modalities, invasive and non-invasive. Non-invasive mainly by coronary Cityangiogram, and we have others as PET and CMR. I will not discuss about PET and CMR because there is a lot of work need to be done, mainly for tracer to target directly the atherosclerosis, and even for CMR because it's not available all time. And we have invasive tools, which is conventional angiogram, IVUS, OCT, and near-infrared spectroscopy. For the sake of time, I will not also discuss all this imaging modality. For coronary CT angiogram, this is what we can see for soft plaque. It's atherosclerosis at early stage, which means it's not calcified. So by coronary CT angiogram, we can see positive remodeling. You can see this is there is a lumen here, and outside the lumen, there is a progression of the plaque with respect of the lumen inside. So everything happens outwardly, and on B, we have this white spot here, which is spotty calcification. It's defined by maximum diameter is less than 3 millimeters, so we call it spotty calcification. And on C, we have low attenuation plaque. Usually we define it by Hounsfield unit. It's in comparison to blood and calcium, and its cutoff, it's 35 or 30 to 70 Hounsfield unit. And on D, we have napkin ring, which is a center of low attenuation surrounded by rim like of low attenuation, which mainly is necrotic core, and the surrounding rim is the fibrous gap. This is very important to detect, and we need at least two of this 4 to define vulnerable plaque. And it's very important because if we have 1 or 2 of this, the risk or the hazard ratio to have myocardial events increase. And this is by angiogram and IVUS how we define positive remodeling. You see, this is our zone of interest on the middle, where there is progression of atherosclerosis. If we take the ratio of diameter between the zone of interest and the proximal, it should be more than 1.05, or by CT angio should be more than 10%. And this is negative remodeling, again, but now the ratio is less than 0.95. What's plaque progression and regression? Usually we define progression based on lumen diameter and percentage of stenosis. And if we repeat coronary angiogram after treatment or later, month or later, and we found an improvement in lumen with some luminal gain, then plaque has regressed. And this is the traditional way. Fortunately, our field moved and has grown, and now we are able to define progression based on plaque morphology. If you check here at the first image here, we have a luminal stenosis identified at 40%, and we start having here in blue and yellow, we have necrotic core. So if we repeat this angiogram after a while on treatment, and we find, irrespective of lumen, but here, for example, lumen is still 40%, but check the necrotic core in time 2, it get large, and we have a large plaque burden, and either fibrous gap will be thin, so plaque progressed. However, for the down, in stabilization, you see there is a change in morphology and in phenotype of the plaque, and it's now more stable plaque, which means less plaque burden and thickening of the fibrous cap, and start having some calcium. And in this paper published by Dr. Motoyama and Jack, they followed patient who presented with chest pain, and they have traditional risk factors. And here, if you can see, this is one example of these patients. They found here lesion of low attenuation plaque. I'm not able to show you on the up of the screen. Where is this carré? There is low attenuation plaque, and if we zoom in, we have, this is the septal perforator, and when they follow this patient after 7 months, this patient came with acute coronary syndrome. And if you look at the angiogram down, the site of lesion is similar where the low attenuation plaque was present. And on the right of the screen, you can see they conclude that the presence of high-risk plaque feature, which is here low attenuation plaque and positive remodeling, the presence of these two features is associated with increased event rates. And this is the same paper. They extend follow-up for 10 years, and they found just by presence of high-risk plaque, our hazard ratio is 8, and irrespective of presence or no of high-risk plaque, just if we have plaque progression, our hazard ratio increased to 17. So by itself, presence of high-risk plaque is a predictor for cardiovascular events, and the most powerful predictor of cardiovascular events is progression of the plaque. So coronary Cityangiogram has some limitation. Some are related to patient, mainly morbid obese, dense calcification, multiple or small diameter stents, and uncontrolled heart rate or arrhythmia. Plus, we have other limitations such as cost, accessibility, and local expertise. Now, for invasive modality to detect atherosclerosis, we have a traditional way, conventional angiogram, which has some limitation because it's 2D luminogram, and it's usually depends on the view, on the projection from which we are looking at the lesion, and cannot characterize the vessel wall or the extent of atherosclerosis in absence of luminal stenosis. Other modality is imaging. We have intravascular imaging, mainly OCT. OCT, it's optimal coherence tomography, which is a near-infrared light-based imaging technique. And because it's higher resolution in comparison to other intravascular imaging, IVUS has a good role to detect atherosclerosis at the early stage. When should I use OCT? Contemporary guidelines recommend usage of that OCT should be used in stent failure and in some patients where in order to optimize our stent result, but yet the use of OCT is not limited to this aspects. And in our for our topic today, I will limit the explanation of use of OCT just for plaque morphology in order to characterize the plaque and identify atherosclerosis. So in order to understand OCT, we have to be familiar with two nomenclature, backscattering and attenuation. Backscattering is brightness of signal, and attenuation is how rapidly the signal drops off. See, this, anytime we see OCT, mainly cross-section, we have three structures. We have vessel wall inside, lumen, and we have catheter. I don't know if we can see it here. And we have vessel wall. So this is the main three presence on for cross-sectional OCT. And if we do zoom in here for vessel wall, which is important for us now, we have three layers. We have intima, which is the inner layer, followed by media and adventitia. To make it simple, it's bright, black bright. This is the simplest way to define three layers of normal artery. And this is how it appears. Normal vessel, we have bright, dark, bright layers, and we know that atherosclerosis usually starts at the level of intima media. So anytime we are not able to detect or to differentiate intima and media, so atherosclerosis is present or started. However, we have, for intimal thickening, we have two types. We have adaptative intimal thickening and pathological intimal thickening. we have to know that intima thickness, normal intimal thickness is less than 300 micron, and it's considered abnormal, but it's adaptive if it's between 300 and 600 micron. So here on the left of the screen, we start having some thickness of the intima, mainly at 7, 8 o'clock, but it's not exceeding 600 microns, so it's considered as adaptive thickness. However, on the right of the screen, also at 7, 8 o'clock, we have a thickening of the intima which exceeds 600 microns. So here it's pathological intimal thickness. And this is how it appears lipid by OCT. We have check from 11 to 7 o'clock. We have a structure. We are able to see this bright, but after that we cannot define any other layers. So here it's abnormal. So we have high backscattering, which is bright, followed by high attenuation. We are not able to delineate border, even its diffuse border, and you are not able to see behind. So it's typical for high attenuation, and it's typical for lipid. And this is for macrophage. You remember the slide I show you for a plaque formation. We have a lipid, and we need recruitment of macrophage in order to digest LDL to form foam cells. This is macrophage. This is inflammatory cells, and it's typical in OCT. Look at 8, 9 o'clock. We have this shadow, heterogeneous shadows backward. I don't know if you can see it here. It's shadow like this. So this is typical of macrophage. And this is how we can see cholesterol crystals by OCT. Check here below. Here, this is typical of cholesterol crystals. We have this linear band, highly reflecting, and the difference between macrophage and cholesterol crystals, there is no this backward shadowing. This is very important. Why? Because now by OCT, we detect lipid, we detect macrophage, and we have cholesterol, which will be ingested by macrophage in order to form foam cells. Then we need vessels to feed this whole process, and this is how microvessels appears by OCT. It's a black hole, consecutive on 3 frames with no connection with the lumen. So, and all this lead to formation of fibrous gap. Fibrous gap is the first layer overlying the plaque, and we say it's thin cap when its thickness is less than 65 micron. And if it's thin cap, it means it's prone for a rupture and causing event. And look here, for example, at 7 to 8 o'clock, it's thin fibrous cap if we compare to other surrounding. And this is how it appears, a plaque rupture by OCT. Look at 5, 6, 7 o'clock. We have this discontinuation of the fibrous cap. This is typical of plaque rupture causing acute coronary syndrome. And so this is part of work I did last year, because now we are talking a lot about artificial intelligence, and we just install a new software here in Cath Lab for OCT. And in this work, we try to define every structure of a vessel wall, and in order to teach it to artificial intelligence to build a software. So no need for human intervention. Software will detect automatically all this stuff. Here we highlighted fibrous gap, lipid burden, and it will be detected automatically. Now, back to our case. Remember, we said this lady had chest pain for 2 months. We did the exercise stress test, was negative, discharged her. After a time, she came back with non-ST elevation MI, and she was diagnosed with spontaneous coronary artery dissection. And now it's the time to meet her on SCAD clinic as was expected. So At that time, I was running SCAD clinic at McMaster, so I had the chance to see this patient. And unfortunately, she's still complaining of chest pain despite 8 months of first presentation. And she still has angina class 3. So we discussed with her based on all our data that if we have SCAD should be resolved within 4 to 6 weeks, and it's not normal to still have same symptoms despite all this time. So we decided to repeat her angiogram and to see if we missed anything. And this is what we found. What's this? Okay. So this is the same appearance as first angiogram. We still have same appearance in proximal and LAD and even apical LAD. So as I said, it's not the normal behavior of SCAD after all this period. So we cannot treat what we cannot see. So we decide to do imaging in order to understand if there is any missing or any things we are not able to understand. And this is the OCT of prox and mid LAD. Remember what we said for the definition of vulnerable plaque detected by OCT. Look here, from 12 to 9 o'clock, we are able to detect 3 layers, bright, dark, bright. But look at the intima, it's thick. And the thickness of intima is around 600. So we consider it as adaptive here. However, in opposite side, from 1 o'clock till 8 o'clock, we have the thick intima, which exceeds 600 micron, and followed by high backscattering, high attenuation, and diffuse border, which is typical of lipid. And if you check here at the 5 o'clock, it's typical of macrophage. So we have fibrofatty plaque, we have high lipid burden because it's more than 180 degree, and we have macrophage. So we have typical of inflammatory process of atherosclerosis and typical for a soft plaque. So, and it's not SCAD. So by imaging, we ruled out SCAD and we identified the diagnosis of atherosclerosis. And this lady, we did the stent in her and discharged home. So is plaque progression modifiable? I think this is an obvious question asked always by our patients. Sure, plaque can be regressed, and we have some strategy. And sure, we are not able to clean our arteries. The strategy to regress plaque are lifestyle modification, mainly diet and exercise. And we have pharmacologic statin, PCS Canine Inhibitor, and Colchicine. Just a few words about this strategy. In this meta-analysis, we can see that it showed that atheroma volume regression can be reached more than 20% by adding statin in comparison to control group that typically progressed around 10%. And this is how statin act on vessel wall. Check on middle and on the right cross section. We have plaque burden, large plaque burden, and infiltrated by cholesterols and microchannel. And the effect of statin is to change phenotype of the plaque. It make it more calcified, which means more stable, and less plaque burden, and more thick fibrous gap, which means less likely to rupture. And in this imaging follow-up of effect of statin on the vessel wall, on the left bottom right, you see we have a fibrous gap where there is arrow, which is thin. This is a baseline, and after 9 months of statin, you see fibrous gap get more thick, which means plaque is more stable. And this is follow-up by coronary Cityangiogram, you see at baseline for a statin-naive patient as after taking a statin, you see this green, it's mainly a plaque burden, and on follow-up, you see there is less green, which means less plaque burden, and we have more white, which means more calcium. So plaque is more stable now, and fibrous gap is more thick. So there is complete change in phenotype of the plaque. And this is a Glakov study, studied the effect of evolocumab on progression of coronary disease in statin-treated patient. And they found if we add PCS Canine Inhibitor to a statin, there is a reduction in atheroma volume, which is with significant P. And finally, for colchicine, which is an anti-inflammatory drug, this is LODOCO 2 trial. It showed that there is significant reduction in low attenuation plaque volume if we add colchicine in patient with acute coronary syndrome. And don't forget, low attenuation plaque by itself is the most predictor of cardiovascular events. I will end with this slide. We have just to understand that atherosclerosis is the primary disease. And as secondary anatomic consequence, we have stenosis. And ischemia by itself is a tertiary physiologic consequence. So in order to target it's better to target atherosclerosis, which is the primary disease, instead of going behind ischemia. So by the end, we ask all the right questions in exactly the wrong order. Thank you.
Okay, thank you. If you have any questions, you can raise your hand and we'll unmute your microphone, or you can place a comment in the chat box. So maybe I'll start, Ali. So how, with what you presented today, how is this gonna, or how does this change how you approach cases in the cath lab? Because you're talking about treating asymptomatic disease, if I understand what you're saying correctly, as opposed to treating patients when they've developed what we deem to be ischemia. And correct me if I'm misinterpreting what you stated.
In cath lab, unfortunately, we are not seeing asymptomatic patient in our cath lab. Usually asymptomatic patient start by seeing her family physician or cardiologist in the clinic. So in cath lab for asymptomatic patient, it's unlikely to deal with this kind of patient. However, the main idea is to detect atherosclerosis at early stage in the clinic. So we have to pick our test for the right person in order if we have a suspicion for atherosclerosis.
There's a question in the chat from Dr. Beanlands. When should patients get OCT in the cath lab?
Thank you, Dr. Rob. Based on guidelines, we have some recommendation for OCT, mainly in case of stent failure or for stent optimization, especially in high bleeder patient, and we need to shorten the duration of antiplatelets, so we get an optimal result guided by imaging. So we are sure and we are confident if we need to stop the dual antiplatelet at early stage. There is other indication, mainly in diffuse lesion or in severely calcified lesion.
Okay, so I have a question perhaps for Derek and Anyang there in the audience. OCT, what's the learning curve to learn how to do it properly, interpret it, and cost per case for this modality?
So I think there is definitely a large learning curve, and I think that's
So definitely there is a large learning curve. And I think one of the reasons why people struggle is that when we see these talks, people give very great examples in terms of beautiful images, as Ali has shown. But when you're doing this clinically and you're running this through an entire coronary segment, it's often very easy for novices to miss certain things. Or if your suspicion in the first place is not high. So I think that learning curve is definitely a challenge. And as Ali showed you, one of the things that's coming down the pipeline is the companies actually working with these core labs to establish AI algorithms to facilitate people or drawing their attentions to certain structure. The system that Ali talked about in terms of Ultron system right now, it's sort of a proof of concept, but already the system's already able to, on a segment by segment basis, identify calcium and where calcium is. And certainly by looking at that, my guess is that they're going to proceed to actually look at specific other plaque morphologies and ultimately identify these vulnerable plaques. And I think back to your question, Ali, in terms of what that utility is, I think in certain individuals, by showing them that there are these vulnerable plaques, definitely it will heighten the need for or prevention towards the future. But I think it also potentially in the cath lab allows us to say that if this is a high-risk lesion based on these features that we can identify on the imaging, it might move us towards specifically targeting a specific area, even though stenotically it's not tight. In terms of your question on cost, it's $800-900 extra, and it definitely eats up time. So I think that's a big deterrent in terms of routinely using it. And then the last part is that, as some of you know, that the US have recently instituted guidelines that suggest that routine coronary imaging on interventions, and certainly that has risen some controversy. But I think it's coming down the pipeline, and at least for our interventional training, it's integral in terms of part of the education to know how to properly interpret both OCT and IVUS, and also think about using it in the right context. AY, do you want to? By the way, AY is our resident OCT expert, so.
I suppose you've already answered all the questions about the utility, which is the main thing. The other time OCT is exceptionally good is when there is question about what the diagnosis is. So we often see patients that have troponin this history doesn't fit, the ECG doesn't entirely fit, the area of regional wall motion abnormality, similar patients that I had just yesterday. So the OCT is exceptionally good at this because it can detect whether there's any plaque rupture to explain the mechanism. So more often than not, I'll use it to exclude a plaque rupture instead of the more routine use, which is stent planning, size, and prevention of under expansion of stents. I think the rest of the questions have been answered by Derek adequately. And one final thing about research is that, as you know, Sharon and the transplant team has been utilizing OCTs to try and tease out what the mechanism is. And there is a specific appearance to calves, which is a repeated thrombosis. And you see a layered appearance, which is not shown today, but that's very typical.
I was going to ask Ali a question. So the case that you show of this 31-year-old woman, and everyone has that assumption that this is SCAD. And I think most of us going in there would have thought SCAD as well. And the irony is that they showed a very similar case this year at CCC from another center where, again, young woman gets labeled as SCAD, and people sit on it for weeks with this woman in hospital. I think looking at these two cases, Ali, how would you have treated things differently? Do you think that in that scenario, you would have advocated routine coronary imaging upfront and recognizing that there are risks, of course, in terms of putting an OCT catheter and then putting in dye in someone that potentially is SCAD? So having seen those two cases, what is your lesson learned, and how would you treat differently, let's say, with young women presenting with ACS in this scenario?
I will divide this question into two ways. First one, to diagnosis. So in young patient who has no symptoms, no risk factors, and she presented with symptoms of cardiac angina. So they went for exercise stress test, which is either negative or positive, but it will not give us any idea about the anatomy of the coronary arteries. So, and it will, functional test will change nothing on the treatment unless it's positive. However, anatomical test, it gives us an idea to expand our treatment or expand for further evaluation. So from the beginning, I will not go for exercise stress test on this lady, and I will go for anatomical tests such as coronary Cityangiogram. For the second part of the question, if I am confident to advance a catheter while I suspect SCAD, no, I'm not confident. Usually SCAD, it's a diagnosis of exclusion, and if we have high suspicion of SCAD, we can diagnose by angiogram. And as this lady had TIMI flow 3, there is no disturbing on the flow, and she has no pain after that, so I will be confident to send her home on treatment, just aspirin, and I was a close follow-up on SCAD clinic for if symptoms persist or not. But at the index event to advance a catheter, no.
So back to that first part that you mentioned, do you think a CT follow-up in that scenario would have been something that you would have considered in retrospect?
Yes, especially for the proximal and mid segment, because it's a big vessel, big diameter. So if it's a SCAD, it will give us an idea by coronary Cityangiogram, but not for the apical. If you remember the apical, it's the same after 8 weeks, which means this is a normal appearance of the artery in this lady. But due to small caliber, coronary Cityangiogram is not able to give us any information.
Great, thank you.
No question.
Okay, that's great. Thank you for the discussion. That brings us to the end of this morning's rounds. Thank you, Ali, very much for your presentation. Please join us next week. The invites will go out through emails for rounds. Please sign up and join us. Have a good week, everybody.
Thank you.
Thank you very much, Ali. I'm sorry the pointer didn't